You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by a continuing education company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education, elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
This is diabetes primary prevention. So we have a 65-year-old woman with a history of type 2 diabetes and hypertension and an elevated CAC score of 400 Agatston units. Taking metformin, 20 milligrams, dose limited by severe myalgia at a higher dose, so unable to tolerate high-intensity statin or any other statin. She's tried 4. When you're a lipidologist, you just see more statin intolerance. Also on an ARB and metformin, she takes ezetimibe 10 and low-dose aspirin once a day. Based on that calcium score, the risk-benefit would be in favor of aspirin. BMI in the overweight category, 27. Blood pressure well-controlled, 124/76. LDL is 105 milligrams per deciliter. So high calcium score, diabetes and hypertension. HDL 45. Trig's a little elevated at 155. LPA is normal at 48. Nanomoles per liter, and the A1C is in that now pre-diabetes category. So what would you do next after refocusing on diet, exercise, and lifestyle changes? Would it be no changes, repeat evaluation in 3 months, add a PCSK9 monoclonal antibody, add inclisiran, add bempedoic acid, or add colchicine? Okay, so 47% want to add a PCSK9, 50% bempedoic acid. All right, and if we go back, I'm just going to go back for a second. Remember, her LDL cholesterol is 105, okay? So just remind you again about the CLEAR outcome study, all right? The primary prevention cohort, which made up a significant number of the patients in the trial, more women than men, had a 30% relative risk reduction. And how did you get into that trial? You got in if you had diabetes, 65 for women, 60 for men. You got in if you had a coronary calcium score greater than 400. Her calcium score is 400. Or you got in if you had a high risk score. And they actually used the Reynolds risk score, which is an older score that was tailored more for women. It has C-reactive protein as part of it. We don't use it so much anymore. And they used the SCORE, which is the European risk algorithm. But you could use pool cohort, or you could use PREVENT in this setting, I think, to try to identify these patients. So clearly this patient, by history of diabetes and the coronary calcium score, is the type of patient that was enrolled in CLEAR outcomes and benefited from using bempedoic acid. Now, that was a statin-intolerant population, but that's real-world medicine. These are the patients we all often see. So just reminding you that the drug is approved for this type of patient and has clinical outcome data to support it. And again, Dr. Martin mentioned a couple of times now the role of coronary calcium screening also to help you risk-benefit aspirin use, all right? It's not a wing-it kind of thing. We've got good data, and this is one of the reasons, I think, to use calcium scoring. And if that score is above 100, they clearly are in the benefit versus the risk category, assuming they don't have a history of bleeding ulcers or, they're not falling all the time or anything else that's going to change your use of it. But I often start patients on aspirin when, say, a cardiologist has seen them and hasn't, just based on this information. Any other thoughts on this?
Yeah, completely agree. It's,
So that linear line is the number needed to harm?
Yes.
Yeah, that's what they need to
right.
know.
So showing that once you get in those top categories of calcium over 100, there's a clearer, a greater benefit than harm. And so, we don't have the randomized data, so that I would acknowledge that this is not as strong as all the data we have for going aggressive with lipid lowering, but it makes sense if we put all the evidence together.
I think this is important because there's been so much in the news about stopping aspirin.
Right.
All this data about folks without a history of heart attack or stroke should never be on an aspirin. First of all, that data is for starting, not stopping.
Yeah.
And second of all, there's a bunch of people that fall in the middle range.
Right. And in this case, the calcium score is over 400, so it's in that range that's actually above the secondary prevention threshold of 300. And in secondary prevention, everybody gets aspirin, antiplatelet therapy. So it's a bit odd then to not do it when you have a primary prevention person who meets that same level of risk, because risk is really a continuum, even though we dichotomize based on events.
Yeah, no, I think that's great. And, so just another tool to think about when you're seeing your patients. I thought I'd just show you some information from another great paper from the NLA on statin intolerance. I put a little reference thing in the top and you can download it, but they really spend some time thinking about how to talk to patients about this and how to define it. And this concept of complete intolerance versus partial intolerance. People will often come in and say, oh, I can't take statins. And when you interview them or have a discussion, it's that they tried one statin and had a side effect that doesn't make any sense, and no one has ever tried them on a statin since. Or they can take some statin, just not at the highest dose or the optimal dosing frequency. So I think it's important to make that diagnosis, and this is a wonderful paper, kind of overviews kind of the concept of complaints people have and how rare or common they are, myalgias versus myopathy and rhabdomyolysis. Other symptoms that probably may not be related to statins, like mental confusion and memory. The data really doesn't seem to support this as being a side effect of these drugs. The nocebo effect, which has clearly been reported in statin trials, and how we can impact certain things that might increase the risk of statin-related side effects. Case conclusion here was with the addition of bempedoic acid, changing ezetimibe to fixed-dose combination therapy, added 180. With additional diet and lifestyle, the LDL is now 68. So the LDL is below that cutoff of 70, which I think would be reasonable. Now, you could make the case with a CAC score above 400 that their LDL could be below 55, right?
Right. Yeah, I think you have the option to go that way. So the folks that answered PCSK9, I don't think are wrong.
No, not at all.
I think this is a shared decision with the patient. If they had a preference for oral therapy versus, and it could either
And you
way.
could probably get it approved. The ACC expert decision pathway, remember I told you, gave you 1,000 as the recommendation.
Right.
But as Dr. Martin has pointed out, and there's actually a great NLA paper on CAC scoring, I think Mike was part of that, Mike Glaha, where they recommend 400 as the cutoff for PCSK9 inhibitors. And a lot of payers, if you show them a CAC score that's even above 300, will let you get a PCSK9 inhibitor.
What did you originally say the A1C was?
I think it was 6.1 with treatment.
And
The patient had a history of diabetes, but now on metformin and lifestyle. So they're not officially diabetic.
and they were on a little bit of statin. What were they on?
20 of it's worth.
And you continue that.
Yes.
So does bempedoic acid affect A1C at all?
If anything, it might improve it. It was originally, it's interesting. So bempedoic acid is an ATP citrate lyase inhibitor, but it's also an AMP kinase inhibitor, which is how metformin works. And when bempedoic acid was originally developed, it was being developed as a metabolic syndrome drug. It was supposed to impact weight, it was supposed to impact A1C and lipids. It was just too complex a development pathway, and AMP kinase inhibition, I kind of like it to, like, you're driving along the highway at 50 miles an hour and you want to slow the car down, so you pop the hood and you throw a wrench under the hood. It'll slow the car down, but you don't really know what happened. And so they switched to the LDL-lowering pathway. But the drug actually is neutral, if maybe a little beneficial on weight, and it's positive on blood sugar. So it's a great drug to use in a diabetic patient.
There you go.
Thanks for watching. If you found this discussion valuable, be sure to like, subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.